Good afternoon, everyone. Uh, Welcome to a very special edition on a very special topic, which may well define the life of each one of us singly and collectively on the theme of towards the long term holistic Medicare systems, the case of COVID 19. What began as a casual chat between Dr. Paul and me sometime in June gradually built into an event which we are now going to see unfold. And through the kind of informal exchanges that the two of us have had, sometimes regularly, sometimes infrequently, we thought we should spend some time tossing this topic around. And later on, Vora Sahab, with his usual support for anything which he finds worthwhile, both for pushing the boundaries further and for, in this particular case, India International Center's mission, uh, through his support behind it. And Dr. Reddy wasn't too far in agreeing to join in, especially given his own reputation and a unique perspective on medical practice and education. By design, I have decided to skip the introduction because there is no point in telling you when Dr. Paul did his MBBS and when he joined AIMS and what is his specialization and how many research papers he has published and what decorations he has received. Allah the same for Dr. Reddy, and the list for Vora Saab is far too long even for my memory because I have known him only for the last 35 years, whereas he is, if I remember right, a 1948 batch IAS officer, and God knows if there was anything that he hasn't seen. So we take it that everyone is here because of a dedication to a cause and nobody needs an introduction, which brings me essentially to the kickoff of this program. And I was wondering whether I had not committed once again something which I'm branded for, rushing in where the angels fear to tread. But the trouble is, once you are in a ropeway, you can't get out. And so here I was holding the baby and expecting all my friends to pitch in. This is not just a discussion on the medical aspect of COVID, nor is it a discussion on the pathogens and all that goes along with it. That is a valid area of discussion. But let me begin by setting the pace of the conversation by a quote from one Pema Chodron, who is a Latin American celebrity, where he quotes the South American experience in the following manner. The Navajo teach their children that every morning when the sun comes up, it's a brand new sun. It's born each morning, it lives for the duration of one day, and in the evening it passes on, never to return again. As soon as the children are old enough to understand, the adults take them out at dawn and they say, the sun has only one day, you must live this day in a good way so that the sun won't have wasted precious time. Acknowledging the preciousness of each day is a good way to live, a good way to reconnect with the basic joys. And I thought this is what this program is about, because we are here to look at what was termed as a holistic long-term Medicare system, the case of COVID-19. Now, to set the context and the issues to trigger off the conversation, I would like to make a reference how this has become a smokescreen of some administrative interventions, not only in India, but more so in other places of the world. Just consider the case of HB1 visa or some illustrations of governance in country X, country Y, passed off in COVID times, which has nothing to do with COVID at all. But we are going to talk of COVID as a human experience. So I think it's necessary to define the terms, the characteristics, and the features. And one of the characteristics of the times is certainly the uncertainty, a semi-confusion, the uncertainty on what works, what doesn't, and to what extent. almost every attempt to create roadblocks and slow down the progress, be it sanitizers or gloves, are embedded in some kind of controversy. You plan an intervention and somebody comes up and says, but you see, however, the research is mixed and this could have a following side effect. This has a huge impact in creating sensible responses to situations, because if everything is mired in some kind of a debate, then the person who knows little of the scientific background and is yet to pass through the times only adds a sense of confusion to his sense of anxiety. Therefore, my first recommendation is we should consider the possibility of having a reference framework embedded in a system that is easily accessible, to whom you can turn to for advice and what is the scientific position on a given thing. And this cannot be just left to channels, media, or individual good Samaritans who try to push for the cause. The emphasis on long term is not just a number of years, but you put together long term with holistic, and you put it in the context of medical practice and extension. You have the components of the emergency healthcare, you have safety engines of healthcare, you have emergency case development issues, and therefore you are really left with prevention tools which serve to mitigate the risks, and some kind of stabilization of the aftercare systems, because whether you go undergo a prostate surgery or any kind of medical intervention, in most of the cases, the doctor turns around and says, this is no guarantee that it won't reoccur again, unless he has taken that organ out completely because it was not considered relevant for the bodily system. Therefore, need to integrate it with other essential demands on Medicare is essential, because whereas COVID is a major risk, and we know it at the back of our skin, life is not confined just to COVID risks. There are any number of diseases which can and do happen, and any number of events which have happened to show that whereas COVID must be responded to in its fullness, it cannot be the sole purpose of channelizing all medical effort or expertise. Now, that is such an obvious statement that one is surprised how in the early responses there was, in many parts of the country, a kind of tilted balance which added to the suffering, and suffering does not necessarily ride on COVID. Therefore, I think the first operational requirement would be to define the categories and the units. The situation in the mohallas, the localities, the habitats, the districts, the states, the nations, and I might add, aggregation of nations regionally have many variations, and there then becomes the first challenge. And I admire the kind of statesmanly vision which people like Dr. Paul and his colleagues have been able to give via Niti Aayog and his colleagues in the profession, where they are dealing with a situation where the data is weak, the perspectives are to be formed up, there are multi-layered situations, and yet they are trying to tackle the situation. My own recommendation is, and this again can be tossed around, is we need to focus on information documentation, information clearing activity with specific focus in terms of the region of reference with clear-cut deliverables. I am setting these agenda items for conversation not to limit what others may wish to say, but to give a sense of direction of purpose and seriousness, because Vora Saab is quite clear, this is not the end of the road. We are probably taking the first baby steps. We have distinguished people, not only because of the eminence they have achieved in their personal choices of careers, but also the range which they cover. And I don't have to tell you what is the specialization of Dr. Paul or Dr. Reddy, or the kind of rich experience which Vora Sahab has. They will be reflecting that in their comments. But I'm going to stop there and turn over the centerpiece remarks now onwards for the next 5 minutes or so to Mr. Vora to set the thinking forward in terms of his opening remarks, which will be followed by a 20-minute presentation each by both Dr. Paul and Dr. Reddy, and we will then be in a conversation to highlight some of those issues, and we shall play it by the ear because this is such a seasoned group that the very fact that we have been able to put it together is a testimony to their commitment to a much larger cause than their individual brands, if even that. Over to you, Vorasa.
Well, good afternoon, everybody. I'm very happy that Dr. Paul has found time to be with us, as also Dr. Reddy. It's very interesting that while we look for experts and specialists whenever we organize a good program, this evening's program, all the experts, the invited guests, also happen to be our privileged members of the IAC. Dr. Reddy has been with us for almost 3 decades now. Dr. Paul joined us somewhat later. Professor Gautam has been with us also for several years. I think Professor Gautam has given a kind of introduction which is perhaps immensely intellectual. I would like to de intellectualize it and say certain things in very simple terms. Now, why are we gathered this evening to hear Dr. Paul and Dr. Reddy? Simple reason is that this particular viral epidemic, which has become a worldwide epidemic, pandemic, is now embracing over 19 million people all over the world. And over 700,000 have died from this illness. In India itself, we've crossed the 2 million mark and we've lost nearly 42,000 of our citizens. So I would say that keeping this in mind and the enormous disruption which has taken place, which has affected the lives of several hundred million Indians. We are a large country with a large population, nearly 140 crores now. And out of this, we have a very sizable percentage of our population, though it is decreasing progressively, who are below the poverty line, the international standards which define poverty. Now, these people, even in the normal times, have no access to medical care, to health care of any kind. They die when they fall ill. They have no money to go to private hospitals. Government hospitals are very crowded, as all of us know. So there is a particular background to this evening's discussion. When Professor Gautam talks of long-term and holistic, I would say the simple situation is that we have a particular size of the country, we have a size of the population, we know the rate of growth of our population, we know the extent of people who are in the poverty zone. We know they don't have any access in the normal course to medical care. Now, over it, we juxtapose the pandemic and then try to look forward and ask Dr. Paul and Dr. Reddy what would they advise requires to be done in the coming years by the government of India, by the state governments, by the industry, by the private sector, by the NGOs, the civil society. It is not something which the Niti Yog can do. It is not anything which Dr. Reddy through his foundation can do. I think the whole country, there has to be a nationwide standing operating procedure when a calamity of this dimension takes place, which is not coming to an end, by the way. Then who do we blame? Do we waste time in abusing each other and complaining and that there are no beds and there are no PPEs and there are no ventilators and so on and so forth and no drugs available in the market or the black marketing going on? I think all this is not productive. We have to have a sense of where we are today in terms of health management. What are our resources? How are we deploying them? Which are the segments of our population which even today are uncovered? And God forbid, when an epidemic takes place like the one we are passing through, then what is it that we need to do? And how is it we need to do that? Through what mechanics, through what ages? I'll, Dr. Paul, for the sake of my own experience and for triggering a debate. I would just refer you very briefly to to um, to the post-independence period. I joined service in the late 1950s, not too far away from independence. And those early days, we did not have financial resources, we did not have medical colleges, we did not have the kind of wherewithal which Niti Yoga is talking about today. But we had one thing which we don't have today, and that is that every district, and I served for many years in the field, we had district public health officers. They were dealing essentially with communicable diseases, but also with non communicable diseases. In those days, if I may recall now, something which is not known to the present generation, people were dying in thousands and thousands from malaria, typhoid, diphtheria, whooping cough, tuberculosis, and so on. Now, all that is behind us, fortunately, and we have now cancers and other problems to deal with. But this band of public health of functionaries all over the country, let us not forget that they did enormous service, and we saw the eradication of smallpox, which is not a small matter in terms of health management or talking about achievements in the health arena. So, but over a period of time, post partition period, that we grew up, we had colleges, we had nursing colleges, medical colleges, the emergence of specialization, postgraduates, super postgraduates, super specialization, and in all our planning processes in the erstwhile planning commission, there was a concept of village-wise dispensaries, block-wise primary health centers, subdivisional-wise hospitals, small hospitals, 20-bedded, 15-bedded, district-level hospitals, fairly well equipped, more beds, and then if this particular infrastructure referred a particular patient, then they would go to tertiary level care, what we call the PGIs and all India institutes and so on, where both Dr. Reddy and Dr. Paul have served with great distinction. But that didn't work out. I happened to have the opportunity of serve in the health area, and I found that this jumping of levels, somebody is ill in Rohtak or Hisar or Ambala or Firozpur, then he travels the whole night to come to All India Institute or go to PGI and not get a bed there and lie on the floor or lie on the roadside and perhaps die. So, in that background, Dr. Paul, it would be immensely beneficial to hear from you how we are looking forward into the future, what Professor Gautam calls holistic, long term, and so on. All that these are semantics, these are words. But the basic thing is what kind of scenario are we wanting to build in the next 10, 15, 20 years that when we have, God forbid, another pandemic of this scale and this dimension, this severity, which has caused so much economic devastation, millions and millions of our daily wage earners who lost their living, lost their source of livelihood. They walked back home on foot, on cycle, on rickshaws, in buses, in trains. Many of them have died on the way, died of hunger, died of illness. So we have a very difficult situation at hand, but not forgetting that we are a very large country, very large population. We have problems of economic diversity. So what is the role of the private health sector? Today, fortunately, unlike 10, 15, 20 years ago, medical care is available at a given cost. Now, the problem, Dr. Paul, has been for many years, as you know, that this particular species of healthcare, medical care, is not accessible to the poor, to that segment of society which is economically downtrodden, socially depressed, and so on. So, therefore, we have to think of ways and means of the national level coordination between states and the center, what kind of arrangements of health infrastructure, organizational arrangements will be there, which will go into action the moment we have a problem of the kind that we are facing today. That we don't have to waste time in blaming each other or talking about how to get equipment from where, at what cost, and so on. We need coordination between the union government, all the state governments, union territory administrations, the entire private sector, medical care sector, industry, particularly the pharmaceutical industry, which makes medical equipment, diagnostic equipment, ventilators, and so on, and oxygen. Now, when it comes to looking a little beyond the national frontiers, because the disease won't look only to frontiers; it is traveled across the world. Then we look at the role of international coordination or international collaboration, the role of WHO as a UN agency which is dealing with health and medical care matters, research, and so on. And then I think we need to see, which is a question of vaccine development. If a network of research laboratories and development laboratory institutions all over the world pool their resources, join hands, then perhaps we can achieve certain targets much quicker time. And if people of the various countries are working on their own separately, individually, that will take much longer. I find from the media that already India has been able to have very good collaborative arrangements, and some results, hopefully, God willing, will be available soon. A vaccine will become available and at a given price, and we will have some support system to deal with the future spread of this disease. So I would say when we talk of multidimensional, as I was telling Professor Gautam, then it goes far beyond, because amongst the many other matters which impinge on health is environment, is ecology, is the biodiversity, which we ruthlessly destroyed in the past years. Now, as I saw some stories, some comments in credible media elements, newspapers, journals, and commentaries on the television, that one school of thought traces the beginning of this problem to animal foods, management of animal foods, the hygiene and sanitation relating to rearing animal food, and the way we store it, the way we sell it, and the way people buy it, and so on and so forth, whether it is making bat soup or eating frogs or whatever. Uh, there is an element, a serious element of the exploitation of our environment, biodiversity, which comes into when we use the word multidimensional. So I don't know whether today is perhaps not the time when we can go into all that. Again, on the economic side, question of which Dr. Paul would know better. When we talk of future arrangements of health infrastructure, managing epidemics in the years to come, of the scale that we are facing. The first question is resources. Where do they come from? Does the center become responsible, or the states also mobilize? Why should the states not mobilize? While it is in the concurrent sector, we need to pool our resources together, both financial, economic, uh, I think medical science, research, and so on. All this will be required to be done. And finally, before I return the floor to Professor Gautam, I would say that side by side with whatever Niti Yog is planning to do, is already doing, the very good things that are done, I think we need nationwide understandings between Delhi and all the state capitals, between state capitals and all the district headquarters and all the Tehsil block headquarters, and villages downwards. What kind of pooling of arrangements, what kind of collaboration, coordination is to be done? Whether it's an ambulance going from point A to point B to pick up somebody, which hospital that person will be taken, is there a doctor there, is a nurse available, is a bed available, is some equipment available? That kind of planning, of course, so it is a micro planning, but it is not that something we have not done in the past. And our medical scientists and our doctors and nurses have enormous experience of dealing with crisis situations. So, what I'm suggesting is when we talk of multidimensional and we talk of holistic, I think we need to particularly keep in mind the kind of standing operating procedures which we must evolve, make known, spread awareness, starting from, I would say, primary schools to middle schools to high schools, colleges, universities, the public at large. We must all know what certain things are all about, what is required to be done by individuals, by families, by society groups, and by the public at large when a situation like this arises. So I will not say anything more except to look forward to hearing both Dr. Paul and Dr. Reddy and the debate that will follow. Once again, while I'll do that at the end, my grateful thanks to both Dr. Paul and Dr. Reddy. Thank you very much.
Uh, Forum with you, and you have brought your proverbial clarity. I'm not going to eat into the time, which is really that of Dr. Paul and Dr. Reddy, but one observation is perhaps necessary every time I hear you speak, and it's a straight lift from Mark Twain, who once following Rudyard Kipling said, between Rudyard Kipling and I know all that is to be known. And the audience obviously didn't take very kindly to it, to which he said, was just a minute, ladies and gentlemen, because he knows everything and I know nothing. So between him and I, we know all that is worth knowing. So whenever I listen to Vora Saab, I'm reminded of Mark Twain's comment. With that, over to you, Vinod. Please let us lead kindly light.
Thank you very much, Professor Gautam. Thank you, Boraji. I'm pleased to be in eminent company. I'm honored to be introduced by Shri Bora, and I'm very pleased to be sharing the dais with my teacher, my friend and philosopher and colleague, Dr. Srinath Reddy. I think the stage has been set for a very wide-ranging discussion on the health system and health sector. Yes, COVID has triggered us to think about not just of today or this afternoon, but also in the longer term. What I intend to do is, because it is still linked to the COVID situation, our context is still the COVID situation. So I would like to share the current status of COVID pandemic, just to set the stage and also to, in a way, contextualize where we are, partly reassuring, partly sharing the concern that we have. And that is the way we design. But I think the points that have been raised by Shri Voraji are extremely important. And I would like to return to them in the course of my second opportunity when I get a chance to speak again after Dr. Reddy. And you do want to come back to them, those fundamental issues of where India should go, what it has done, and so on, and what are the lessons that we have learned. So I am reserving that part for my second segment. But let me begin by showing you what looks like the current scenario of the pandemic, setting the stage, in fact, essentially. Just a moment, just sharing the screen, because we are using data. And that's it. Can you see the screen, Mr. Gautam?
It says COVID-19 pandemic.
Pandemic, that's it. So it is there. All right. So this is the summary. This has already been spoken by Boraji, about 18 million worldwide cases and 700,000 worldwide deaths, and India 2,042,000 deaths. We are now increasingly not looking so distinct from several other nations because of the large population. Our pandemic is traveling. But yes, even now, we have nations which are much worse off to us. But then we have to be very watchful. This is just to show you how to all the distinguished viewers on the conference. Thank you very much for taking time out to be on this call. This is the way the daily cases are rising, still rising. But if you look at the 5-day moving average toward the end of the red line, you might see that there is some kind of a stabilization. I don't know whether it is true or it is random. Only time will tell. But maybe there is something out there which is indicating that we may have moved away from the exponential rise and we may be stabilizing. But that's for only the time will tell. But certainly it is a fact that the first big phase of pandemic in the most populous of our cities and the more active western half of the nation where the original pandemic started and where there were dense populations, there were large cities. So that is truly now reaching some kind of a, or moving towards some kind of a peak, as you have seen in the context of Delhi. So maybe, but then we still have a large swaths of our geography, large swaths of our population which are naive to this virus, and virus loves people. Virus loves dense places. Virus loves irresponsible citizens who don't look after their respiratory secretions and so on, and don't maintain distance. So we are very vulnerable still, and that is very important for us to remember. I show here cases per million because we need to contextualize how India has done and what the way forward for us is. You would like to see that these are nations on the x-axis and these are COVID cases per million on the y-axis. India is 1466 cases so far per million, about less than 1500. And the world average, about seventh month into the pandemic, is around 2500. So we are still below the world average. But on the left, as you see, the longer bars, there are countries smaller than ours who have experienced a much denser pandemic for their nations. And those nation names are obvious for us to see. And then, of course, there are some which are much better than us, and those are on our right side. But the point remains that in terms of the population load that we have, the disease load has still been of a, I would use the word quote unquote, modest level. It could have been much worse. It can still be much worse. We still are in the midst of the first half of the pandemic. The trailer is over. We are still, I think, before interval even now. This is the story on deaths, and from media, we do have a sense of provisional conclusion that the mortality rates in India continue to be low. There could be host factors, but there could also be other factors that we have handled the situation well in terms of response, in terms of honing the home-based isolation protocols, and so on. So we can thank God as well as perhaps take credit that the mortality per million, deaths per million, continues to be low. It is 30 compared to global average of 3 times. That's 92. And you can see countries in Europe which are more than 10 times and much more than almost 20 times on the extreme. And this is, of course, our own demography as well that plays a role in terms of young people. But fact remains that the mortality burden overall so far has been relatively low, on the lower side. But we must also remember that it is the deaths that will be ultimately be imprinted in the pages of history. How many deaths happened in this pandemic in a given nation, in a given city, in a given state, in a given continent? And therefore, we must continue to put sharp eye on the number of deaths. And as a nation, we have set the goal that we will keep our case fatality rate of less than 1%. And I'll come to that in a moment. So deaths are to be watched. It is not the cases, but it is the deaths, the lives that we lose. And of course, Mr. Vora, as you correctly said, also the lives we lose counterfactually by non-COVID condition and the stresses that come with this kind of a pandemic, which are beyond the disease per se. And that's a very important part. So the net and the sum total of all that is the hisab that we have to give to the history. These are case fatality rates, as we know. India currently at 2.0. This is the one that I would like the health profession and the public health and the state governments and the private sector to keep in mind, that we would like to see this below 1% because it is eminently possible. It is truly possible. Some of our states have consistently been below 1% case fatality rate. It is possible. The highest we have seen for a state is around 6 or a little above 6%. We are also learning that case fatality rate, that means mortality per 100 such cases, would come down with time, because we are appreciating how the virus misbehaves in the body of a human being. And we have learned to tackle it by way of a systematic stepwise approach, mild disease to be tackled different from the moderate, to act early, to introduce oxygen early, to introduce steroids early, and of course now we also have a few drugs to deal with. So we believe that we will be able to, in the nut in the sum total, be able to keep it below 1%, and then you can compare it to see case fatality rates are as high as 16 or 15 in countries of Europe. And this will be something which we would like India to pray and the society at large to contribute toward, and also have faith that this is a parameter which is apparently at this point in time within our control. The world average is about 1.5 times, at about more than 1.5 times, at 3.72. We know it, but just to bring the context again, that the pandemic is not uniformly spread. It has hit some states more than others. These are the Maharashtra. These are popular states. These are states with movement, states with a whole lot of activity. Tamil Nadu, Andhra Pradesh, Karnataka, Delhi, UP. But remember, the states that you see on the left side are not really fully protected. This pie diagram may look very different with time, but the fact remains that the pandemic has hit the country at different time points and has progressed somewhat differently, and therefore a lot more is going to come. Even if we have a major peak being passed over, let's say, there will be enough time for the virus to attack the naive population, and there may be other peaks that we have to be conscious of. The converse of this is that now we have learned a great deal about how to control the pandemic. Control a pandemic has two elements. One is mathematically known. That means the virus knows how to go about. It likes people. From 1, it goes to 3 to 4, and then from 3, it goes to 9 to 81. And that, in a way, is predictable. But what is not predictable into an equation is how we stop it, how we create headwinds to this progression by social distancing, by wearing a mask, by hand washing, by using the practices which prevent spread to an individual and from an individual to the family to others. At the same time, how much effort we put in disease control per se, in terms of surveillance, contact tracing, and so on. Now, all this that we do creates pressure for the virus not to progress. And in an extreme case of so-called lockdown, there is very little for the virus to spread because the people are not too apart. Families are far apart, so the virus cannot move from one person to the other. Virus has to physically move from one person to the other, and if we create distances and we contain those with disease and potential disease, then virus finds it difficult to progress. So the final shape of the curve, the final numbers, are an interplay of the will of the virus and the will of the society and the people, and the system, how it responds to the system. And therefore, yes, in the early phases, as we were learning, some states suffered more than others, but now it is our duty to make sure that the states which are relatively less affected, the rural areas, for example, all over that are less affected, should not experience the same onslaught. The cities and the towns that are protected as of now should remain protected because we know how to go about doing it. Just to say here, a very important tool in our fight against the virus is detection of a person who has the virus. And how do we do that? We perform a PCR test, RT-PCR test, and now, of course, an antigen test, which tells me that a person A is affected. Once you have this person A affected, two types of approaches get triggered. One, that you can isolate this person and you can quarantine the contacts, the 10, 12 contacts that this person came in touch in the last few days in a systematic way. And thereby you ensure that this person is now not anymore spreading it to more people. So the whole containment and surveillance strategy is triggered by knowing who is affected. And what is it that starts that process? The testing. And then once you test, you also know who is the person who is affected, looking at in a different way. And this is the person who can now get disease, can become sick, and needs to be mobilized toward health system care, drugs, care, ventilation, or whatever. So the point remains that the single entry point toward control at two levels: disease control, continued suppression of the virus, as well as to save the life of a person who is infected, is the entry point is doing a test. And India has ramped up its testing enormously. uh, when the lockdown happened, there were only about 20,000 tests conducted. Today, it's more than 1.5 crore, I guess, around about that. We are conducting 600,000 tests per day, whereas we were conducting few hundred tests at the start of the second month into the pandemic, let's say a few thousand tests. So enormous capacity, and I'm very proud to say, whole lot of those tests kits are being made in India, and this all happened obviously after the disease hit us. There were no kits of this nature. Now, this slide shows that we are conducting tests to the tune of 473 per million. WHO minimum norm is 140 per million. But then you ramp it up more when you see high positivity rate. The current positivity rate is about 8%. And we would definitely like to keep it below 10%. That means when I throw the net, I pick up 10 people out of 100 as positive, and that seems like a good set. So we have two parameters to go by: have a general net of 140 per million per day, and then if the positivity hits more than 10%, then you add as much more that needs to be added. So we are just about fine. But having said that, you can see that there are states and there are districts where we need to ramp up testing in a huge big way. But we're very fortunate that our testing right now is nearly optimum, and we are in a position to mount 1 million tests per day, maybe in the next 2 to 3 to 4 weeks of time. This shows the green bars are recoveries, and the yellow ones are the active cases. Gradually, the active cases are declining. This news comes in the TV very often. And you can also see that there is stable and somewhat declining mortality rate that I referred to already. This is only recent few weeks. And then if you go back, the mortality rate was about 3% nationally. I want to bring the story of Delhi here just to show that even when you are ravaged by what looks like a very dismal situation, and the confidence of the people is about to be shaken, things can change with scientific approach. Today, it is not time to go into what was done for this, but here is Delhi 1st of June to about first week of August, till about 3 days ago. You can see that suddenly things were going out of hand around the second week of June. And then certain good things were put in place at the governance level, but more importantly, disease containment level, contact tracing, house-to-house searches, redesigning of the containment zones, following that principle that I mentioned, that you take out the people who have infection. And then, of course, preparedness in terms of hospital beds and connecting people to ambulances, to hospitals, as well as care of mild cases in the home setting using pulse oximeters and online support. Some other day, we could do this in more detail, because that brings in those principles which actually control the pandemic, and more of those principles are applied, better off we are. But you can see that in a matter of weeks, the pandemic spread was brought down. We also would like to show you, I like to show you here the UP 4 Zillas, immediate NCR. The same strategy was applied there. Now, UP, Delhi may be unique, but I like you to notice Ghaziabad, which is a 46 lakh population district, also replicated Delhi in their own way. We can say Delhi is special, Delhi is this, that, but here, Ghaziabad, of course, for the virus, there are no lines, there is no state, there is no geographical demarcations. It is just large urban agglomerate that the virus picks up. Gautam Budh Nagar, more or less stable, Bagpat stabilized, and Meerut just about stable. In Haryana NCR districts, Gurgaon was a trouble spot, has stabilized significantly. Faridabad still challenges, but you can see it is stable. Coming to Jhajjar, doing well, Sonipat doing well, Rohtak, we have some setback. The point I'm making here is that even in the midst of something which looks intense, which looks very difficult, and confidence of the people is shaken, the heart of the problem can be tackled, which means reduction of cases that are experiencing infection. It can happen, and mind you, it happened also without bringing in the hammer approach of bringing in more restriction, which of course works. I'll show you that in my next slide. Yes, that works. But here, in spite of life going along as nearly normal as it was, which is still suboptimal, of course, everything is not open, but using a scientific approach, using approach that suppresses the virus, using the approach which raises preparedness of the health system, and using the approach of engaging with people, and of course a lot more people could have done, you can bring the situation under control and keep yourself safe till the time that we can tackle it with a vaccine and so on. This is my last part, to just show you that when you use a hammer approach, and this nation used the lockdown approach rather early in the pandemic, you can see the impact. I want to bring this to your attention because this issue keeps coming up. Lockdown is a very severe measure. It is an extreme measure. It comes at a huge human cost, economic cost, social costs, and so on. And yes, in certain situations, this becomes inevitable. Practically all the countries which experienced a major pandemic had to resort to it someday or the other, for some weeks to many, many weeks. And in any case, much of the world is in any case in different stages of lockdown or de-lockdown, even as of now. I just want to bring to your attention that around the third week of March, going fourth week, you can see there is an exponential rise over 1 week period. Our growth rate, that means today if there are 100 cases, how many are there tomorrow? So it moved from 111, that is 11% growth, to 20% growth in a couple of days. This was the beginning of the real exponential phase, which was detected by the scientific system and people and groups of people. And that is when this advice for lockdown was given and taken. And you can see, starting with the lockdown around the 14th, 15th day of the lockdown, 5th of April, the growth rate was 25, 23%, 22%, rose further because it takes about 2 weeks for the impact. And thereafter, you can see that when you shut down everything, the virus has no way to expand and to reach other people. It happened at a great cost, but it gave us huge time opportunity to put a lot of things in order, and also to be able to contain the spread of the virus. You can see the growth rate is declining. By the second lockdown, it had come down to 4% from the 22%, 23% peak. We believe that it led to saving of lives. And this is effect only up to mid-May, attributable to the first two phases of lockdown. Multiple estimates were done. I want you to look at the estimate number 5 in the last row. This is what we believe is a modest and perhaps the most acceptable number. There are much higher numbers of cases averted and deaths averted, but about 2 million cases were averted in this period of 2 lockdowns, and about 55,000, ranging from 37,000 to 78,000 lives were saved. Remember, mathematically, the initial part of the rise determines the medium-term trajectory of the pandemic. This is a law. And we entered at a stage where we believe is suppressed that. But we also use this opportunity for all-round preparedness, and that must not be forgotten. We created 3.5 lakh beds in this period up to 15th of May, 6.5 lakh isolation beds in addition. PPE production went from almost nil to about 4 lakh to 5 lakh per day. Testing rose from a few thousand to 30 lakh in this period of time. And then, of course, you touched upon in today's context the point of vaccine. Remember, if this phase that we are facing was actually happening in April, late or early May, we would have seen a huge devastation. That was suppressed and delayed. People changed their behaviors. We are closer to cures, comparatively speaking. We didn't have, let's say, even remdesivir in May. Now it is available in plenty. We are closer by 3 to 4 months to the vaccine. If that time it would have taken 10 months, now it would take 6 months, and so on. So every this period that we bought at a great cost has directly saved lives in terms of the COVID related mortality, and also gave us a huge opportunity to prepare. Only future will tell how it pans out in totality. But we did not do what other nations did, which is come into lockdown when already much of the devastation happened, and then it's not even a decision of the administration. It just happens that the country just chooses to shut down. And I just want to say that millions of people were under lockdown in March, April, and even now. So it is something, a choice which becomes a forced choice in the history of such pandemics. I'll stop here by saying that this is a very small story, trying to encapsulate where we are with pandemic. It sets the stage as to where we are. But I would like to say that we are technologically in a very advanced stage of the vaccine vaccine strategy being accessible to people, very actively working on how, if ever the vaccine comes up, and as soon as it comes up, how it will be scaled up. I'll be happy to take questions on that. On the issues of which Shri Boraji eloquently described, I like to come back after Dr. Reddy and on responding to specific questions. Thank you. I think as a nation, we have done reasonably well so far, is the way that we see it. We still have challenges moving forward. Thank you so much.
Thank you, Dr. Paul, for talking of the present and the long term, carrying in between the current scenario, and with your usual flourish of integrating facts and extrapolation. You have established how a situation can be met where the origins and the understanding identification of the causes themselves were vague. That we have been able to stabilize the situation is no small feat at all, because this is stabilizing while traveling from nowhere, a beginning not known, to nowhere. You don't know what exactly to do to suppress a situation, and yet you have been able to stabilize it. In fact, broadly speaking, if I were to put together all that you said, my takeaway was your elaboration of the principles, the action, and the pathways, and that was truly understanding put across in a manner which I think is the purpose of this fora. I will now request Dr. Reddy to come in with his remarks and put it together in his perspective of looking at it in a multidisciplinary approach and what it has to do with medical education and taking it further. But I don't want to preempt what he's going to say. Over to you, Dr. Reddy.
Thank you very much. I think the topic that was chosen today of looking at a holistic integration of medical care is appropriate in the COVID context, but I would like to go a little beyond that, to not limit myself to medical care, but health care, because health also includes the preventive and promotive aspects. And indeed, if we have to look at health, we also have to look at health beyond health care, because health is actually fashioned by many factors in outside the conventional health sector, by many of the influences that Mr. Vora referred to and you two referred to, where health is substantially determined at the population level and even at the individual level by many factors operating in other sectors. However, reverting back to the COVID context, and specifically the health system in particular, we do wish to have an efficient and equitable health system functioning all the time. And clearly, that is where the idea of providing health services across the life course in terms of health promotion, disease prevention, early diagnosis, providing efficient and cost-effective care, which is appropriate and affordable, and also combining rehabilitative and palliative services as needed. All of that are the functions of a health system we desire. But we must also recognize, and COVID-19 has actually given us the sharp reminder, that unless you have an efficient and equitable healthcare system functioning well in the steady state, when we are not challenged by public health emergencies, we will not be able to create a surge response very quickly and efficiently to deal with an emergency when it descends upon us, either in the form of a pandemic or a natural calamity. We have been adapting to this over the years and trying to create emergency healthcare systems. But it is where we have actually faltered is in the creation of a sustainable, efficient healthcare system which is functioning equitably across the whole country and providing the needed services to everybody across their life course. And therefore, the whole idea of universal health coverage, which encapsulates all of these services, comes in very clearly in the National Health Policy of 2017. And that is something that we must aim to deliver and not immediately relax when the COVID-19 crisis is over, whenever it is. So we do need to look at the whole health system and the services it provides, not in a fragmented and segmented manner, dividing into only certain life periods or certain diseases or healthcare demand, across all the challenges a person faces across the entire life course. Even when you look at, for example, the COVID-19, while it is labeled as an infectious disease, we recognize that there are comorbidities which are entirely related to non-communicable diseases, mostly in terms of hypertension, diabetes, cardiovascular disease, chronic respiratory disease, cancer, chemotherapy, and so on. And secondly, we also know that malnutrition can greatly undermine your health. And innate immunity, which is very important for mounting the defense against any kind of viral or a microbial invader, is greatly undermined if we are malnourished. So all of these ultimately bind into a holistic response, even to what appears to be a single virus caused disease like COVID-19. So we do need to look at where we can actually strengthen each of the weaker elements of our healthcare system. And certainly that is where the reductionism of siloed healthcare approaches or even siloed diagnostic approaches have to give way to a much more holistic appreciation of the system itself, and even in terms of an individual's health needs. And even when we are looking, for example, at what is required, we have previously focused mainly on ventilators and advanced healthcare. We then came to realize that primary healthcare and home care are quite adequate for a large number of people with mild illness in COVID-19. And monitoring at home and also trying to find out who are the people they're likely to be in contact with and how to trace them and how to protect them, all of these are elements that do not necessarily belong to an advanced healthcare institution. At the same time, we also recognize that ventilators have been rather blown out of proportion, and oxygen itself, even for sick individuals admitted to hospitals, quite often suffices. And therefore, the whole upgradation of our district and municipal hospitals to make sure that they have a continuous oxygen flow is something that we have begun to recognize and as very important. So we have been given lessons that we cannot focus only on one element of the healthcare, whether it is tertiary care or whether it is only in terms of looking at advanced healthcare being provided in urban areas. But now as the virus spreads, we are looking at how to strengthen district hospitals, how to strengthen urban and rural primary healthcare, and make the whole health system much more competent in delivering all the needed health services, including care of the people who are in home isolation with pulse oximetry, with temperature checks, and if possible, also with blood pressure and other checks. So the idea of integrating all of these care elements becomes absolutely important. We also recognize that behavior change is very critical. It's not just a purely technical function that we are dealing with here. Therefore, our understanding of social sciences and health communication becomes absolutely important. Why are people wearing masks and why are some others not wearing masks? Why are they not wearing them well? Have we communicated our messages adequately? Have we only communicated through mass media channels, or have you created community-based citizen networks of trusted informants and trusted mediators in the community who carry a lot of weight, and also use the channels like women's self-help groups, youth groups, and other community groups, and even influential religious leaders in order to try and ensure that the local community becomes the area of health messaging and dissemination and destigmatization? Have we been effective in our risk communication? Therefore, that brings in other elements beyond pure the technical function of health. And of course, we have to look at even health technologies from a different angle, from the point of view of appropriate use of contact tracing and so on. So we have to integrate many elements over here and bring that into our health system. And certainly, we are also looking at how we have to utilize not only the public system, which has to be definitely strengthened, but the available private care system, as Mr. Vora mentioned. Now, how do we bring them in unless we have had a pre-existing framework where at the primary care level, at the secondary care level, and the tertiary care level, there has been some level of collaboration between the two sectors in a pre-designed universal health coverage framework, which has been set by the government and where the deliverables are clearly defined and the accountability is very clearly also assigned. And therefore, we cannot suddenly rush and be at the mercy of the private sector when an emergency arises. All of these have to be worked out in the context of long-term care and rebuilding of our healthcare system. And that is where I believe we need a much more elaborate plan for rebuilding the architecture of our healthcare system and what I would call a Dasa Sutra Pranali, or a 10-point program. Here we are looking at improving the design and delivery of our primary health care with a great investment in a workforce which is substantially of non-physician healthcare providers who are in the health and wellness centers. Of course, in the primary healthcare, you require doctors too, and we need to ensure that they're available. Better connectivity between the primary healthcare centers and the sub-centers and the centers of higher care. Better integrated care. Now, how do we actually ensure that we create networks of healthcare providers at various levels? And we also need to strengthen secondary and tertiary care. District hospitals, which are long neglected, now have to be strengthened much more. That is where many of the COVID patients could have been treated and are still being treated with oxygen facilities rather than going to an intensive care with ventilators. Medical college hospitals too need to be strengthened, and we need to create more of these institutions in underserved districts and states of the country. And the best place is to attach them to the newly established or upgraded district hospitals. We need to create horizontal and vertical networks of healthcare providers at the primary care level, at the secondary care level, and the tertiary care level, and also create linkages between those networks, between primary to secondary and secondary to tertiary, and all the way back for appropriate bidirectional referral and follow-up systems. And that needs to be institutionalized. It cannot be created overnight. And therefore, we also need a multi-layered and a multi-skilled health workforce. And there we need to address geographical imbalances. We cannot have healthcare workers coming up in abundance in the southern states because there are more medical colleges and nursing colleges, and have central India and northern India and northeastern India not have adequate medical colleges and nursing colleges or allied health professional training centers. And that's where newly established or upgraded district hospitals can actually become the centers of training institutions as well. And we need to redress the geographical imbalance and also create an opportunity for a national medical service where people can actually be posted across the country to redress some of these imbalances. We do need to provide free drugs and diagnostics because that's one of the major elements of out-of-pocket expenditure. We need to increase public financing to at least 2.5% of the GDP, as has been assured in the National Health Policy document, and ensure that we merge all our health insurance schemes, whether they are state and central or employer provided, into a single payer system, which actually provides a larger risk pool and also a larger service package because it actually pools the resources. We need to improve our regulatory and information systems. We need active involvement of the community as well. We need, particularly if we are really talking about COVID, and if we need to mobilize people, we need the community engagement very critically. Why is it that in Bangalore we had the cases going down remarkably, and suddenly everybody opening up and celebrating and going for shopping sprees or having social or religious events, and the cases rising up again? Unless there is a strong community engagement, we'll not be able to find it. And this is where we bring in the so-called super spreaders. We know in COVID, 80%, this is the experience everywhere, that 80% of the cases arise from 20% of the people. Not that they're genetically different. They are the ones who crowd and congregate and then spread to more people. So we have to avoid super spreader events, not treat everybody as equal in terms of their capacity to infect. And that is where the events will have to be very strictly controlled. And that is where the political will as well as public behavior will have to come together. Then we do need, as I said, whether it's destigmatization or health education, active engagement of the community. And Mr. Vora referred also to the public health cadre. Going back to the question of the health workforce, we need to strengthen our public health systems in terms of disease surveillance, monitoring, and effective control. And that's not going to happen only by building up our clinical care systems. So we need to pay attention to that and create public health cadres in every state. We need also to act on the social, environmental, and commercial determinants of health, because they also create the conditions for ill health, or they can promote health. And whether it is environmental and ecological, or urban design and transport and air pollution levels, for example, greatly undermine your innate immunity and make you much more susceptible to the worst consequences of COVID infection on your lungs. So these are the kind of things that we ought to really focus on, even as we rebuild our health system into a much more efficient and equitable architecture. And certainly we have to look at things like water, sanitation, hygiene, urban development and transport, food and agriculture and education. All of these really impact upon our health. So I would say data are also very important, but the data will have to be generated as much as possible locally, dependable data, and will have to be also disseminated as quickly as possible locally, so that local response systems can be decentralized and can function efficiently. So what we need to do, of course, as we build this architecture of the health system with all of these components, ensure that in the case of a pandemic like COVID, of course, the best is to prevent it and to contain it as quickly as possible if it does break through. But we need data-driven, decentralized decision-making at the district or the sub-district level. In fact, I would say even at the village and ward level as much as possible. And we need people-partnered public health if we really have to make public health an integral part of our nationwide response, because without people's participation and active engagement, we are still going to see people not walking around with not wearing masks, congregating in crowds, and putting everybody, including themselves, at risk. So we do need to bring in a much more holistic approach, not only to recreating the architecture of a very stable and sustainable healthcare system, but create a popular movement where health becomes part of everybody's life, not only in terms of their anticipation of needs, but also in terms of their responsibilities to contribute individually and collectively. And if COVID can actually move us on that path, we would have greatly succeeded, even for paying a bit of a price for it till now. Thank you.
Thank you, Dr. Reddy. Listening to you was being reminded of something which I picked up in my Sunday schools, a Daniel come to judgment. The sheer range and depth of your coverage uh, had me chasing you to take down all the points and approaches which you outlined. I don't know whether I did justice to them, therefore, I will not attempt to sum it up. But the concerns which I did pick up is this cannot be left to just highly branded educational institutions. This has to be made something far more open and approachable to public access, which I think was also the implication of Dr. Paul's statement, because what he was talking of in reality is what Jan Andolan can do to a cause if it is pushed properly, and the results which come out therefore. Obviously, within the time spaces which we have, we are constrained by realities of the real world, and there is more to be said if there was more time to say it in. But then there is a conversation patch which has been built into the architecture of this processes. And as I look at the number of questions which have come from the audience, we will need at least the time we have spent on this multiplied by 5 to answer or respond to all of them. So what I've decided is I will sum up the conversation period under 2 posers to both of you, without limiting you on what coverage you wish to have, and then end up with the remarks from Mr. Vora, because he would be the ideal link to bridge what he terms as an intellectual approach and a down to earth approach, because any down to earth approach cannot be effective unless there is an intellectual underpinning, and any intellectual approach does not have meaning unless it has an earthy approach. So I'll expect him to bridge that for the sake of all of us and future guidance, and tell us how best to proceed from where we are. But then to get back to the 2 questions which I've been trying to put together to sum up many of the questions which have been asked, and what you said and what I think needs to be answered. Dr. Paul, you would be the first up on the list, and I would ask you a very simple question. Where are we going with the pandemic?
As I said, a few realities are obvious. One, that some of our states, which I already referred to, parts of the nation, are experiencing a very intense phase of the pandemic, and I do expect that, yes, with time it should now settle down. At the same time, the fact remains that an overwhelming majority of our people, states, populations, zillas are still naive, and therefore the virus will continue to do its mischief, and there will be other areas where such intensity may emerge. Now, remembering the fact that the virus likes density, people's density, population density, it is in a way can be perceived that the future intensity, let's say few weeks from now, may not be as intense as we have seen as of now. Plus, also we have learned to contain the disease, and therefore countermeasures also come into play rather efficiently. So I think yes, we are in the midst of a pandemic. We have learned to tackle it. We still have a long way forward, but if we continue to intensify our personal behaviors correctly and have been highlighted, and if we continue with our containment strategies, we would go on, but we can also go on with our lives. It's not perhaps the best answer to give, but that's the way I see it. I want to come back, Gautamji, to Mr. Vora's question. And if you permit me to respond to that, would you? Because that should not be left unanswered, at least as a starting point for another debate someday.
Yes, I totally agree with you. Please go ahead.
Let's answer that question, because the fundamental question that was posed was, you have seen COVID can destroy lives, can destroy the health system. What we have seen paradoxically is that in the wake of COVID, even the so-called strongest systems failed. Yes, there are some curious exceptions. Thailand, for example, why did it escape? But in terms of classical, hardcore, health systems, they have failed. So we still have to learn that the fact that pandemic of this nature or future pandemics of this nature may actually may never be optimally prepared for, and that is a very eerie feeling. And maybe a totally different paradigm of preparedness will have to be entertained. And you refer to our business of dealing with animals and life and so on. But to answer the question as to what India needs to do for the health system, if you heard carefully Dr. Reddy's exposition, he actually alluded to everything important that should be there. For example, he talked about primary healthcare system, disease control system, public health cadre, health services which are efficient, so on and so forth. Now, I want to place on record here the fact that for all this, there is a cost. There is money. If we spend what we spend, if we put in terms of money and resources what we are doing, we cannot aspire to have the kind of system, kind of healthcare that we want and we want everybody to have. So at the heart of this whole problem is how much money we spend. We want everything, but then how much are we willing to spend? So there are two aspects to this. One is more for health, more resources, more money for health. And then, of course, the counterpoint is more health services out of the money available, and both are equally important. And for the latter, it is accountability, it is governance, it is public health cadre, it is data systems, it is technology, it is the right mix of healthcare workers, it is the right engagement of the private sector. But you have to come back to the fact that we need to be spending more as a nation on health. We do know what we spend, about 1.4% of the GDP. It translates to, by the way, 1,500 rupees per capita. What do you buy out of 1,500 per capita? Please understand that. How can we build great hospitals? How can we build great emergency, an ambulance system? It is how many vaccines can you give? This vaccine itself may cost 250 rupees or maybe 1,000 rupees. We don't know. So I think more investment in health is the voice that the society and all of us should raise. And remember, when you're looking at investment on health, sir, it is both center and the state. What I said, 1.4% of the GDP is put together, center and state. Typically, center contributes about 1/3, and states put together contribute as a whole 2/3. So both the center and the states have to increase. Currently, health is essentially a state subject, but no state is spending more than 4.5 to 4.8% of their budget, whereas aspiration is to have at least 8% budget. We made commitments to raise health investment to 2.5%, 3 to 4% GDP. We've never done it. So can we please raise our voice that this has happened? Create a movement. When the economy is going great, then it looks, when you give an incremental rise to the budget, it looks very nice, but then it is the same proportion as part of the pie. And when the tough times come as of now, then we say, oh, we don't have resources. Now this has to change once and for all. I think that is where a dramatic shift of resource allocation to health has to happen. We cannot have a health system that we want with the kind of money that we have, even if it is best utilized. And I'm voting for using it for the best purpose. We need doubling of the beds. We need specialists to the multiple of at least 5 to 8 times. We need nurses, again, that kind of multiple, and quality nursing and so on. So I would plead here, sir, that clear statements should emerge that so much more has to be done by way of public spending on health, both by the center and by the state, and change this forever. Now, it will provide us cushion to be resilient against future pandemics, and part of the spending will be on disease control. But it is not a guarantee. If you say the most pessimistic view, yes, a new pandemic may be so different, so devastating that even that will fall apart. But that doesn't matter. We have to have a system for healthcare that India and Indian people deserve in the 21st century. Thank you very much.
Thank you, Dr. Paul. When we conceived of the caption of this effort, long-term holistic healthcare, medical care, choose your word, we all pulled in, and we knew that it would be impossible to cover it within the limited time span we had. But then we can be reminded of the fact that while looking at the distant scene, I wish to take one step, and that's enough for me, is a adaptation of an old quotation which has gone around several times, and your contribution towards that is a very important one. I must save another posa I have for you, but this is not the end of the journey. This is perhaps the first major step in that direction. We also need to look at the citizen regulator interface and how do we see it growing. Now, if you could answer all of it together, nothing like it, but it is best to keep the expectation high, just as you have the interruption just when the story of the serial is reaching a peak, and we shall save this for the next round. I'd like to turn very quickly to Dr. Reddy and get him to a theme which I noticed, and I hope it was not by design, tiptoed all around it to escape something which I wanted so badly to hear from him and a lot of other people who know him. How does he see the public health education even more as multidisciplinary than medical education? How does he see the interdisciplinarity in healthcare? And how does it focusing on action to provide better medical support to the suffering and the non-suffering and the people who want to avoid the suffering people of this huge country with its small variations which he so eloquently described. Dr. Reddy, it's
Thank you very much for posing that question. Well, in terms of the health or medical education itself, I think we need a sea change. And I'm glad that the Medical Council of India, currently under the leadership of Dr. Paul himself, is bringing about a much greater amount of humanities into the education and trying to make it more broad-based. As Gunnar Myrdal, the Swedish Nobel laureate in economics, said, health leaps out of science and draws nourishment from the totality of society. Therefore, all of the social forces influence health. And if you're a medical student, you must also recognize that whether you're doing your studies in physiology or in clinical medicine, you are obviously in basic sciences looking at computational chemistry, computational biology, and so on and so forth. Therefore, it's not restricted only to certain areas. And now in clinical medicine, you're getting the whole range from artificial intelligence to health economics to ethics. All of those come in even into the practice of good medicine. And public health actually becomes much more broad-based because all sectors which influence health positively or negatively will have to be studied by public health in terms of what we can call as the social, economic, commercial, and environmental determinants of health. And we see that happening in COVID, we see that happening in other epidemics as well. But even the configuration of a good health care system is also the function of public health, whether the services are equitable, appropriately functioning with the right kind of health workforce who are suitably skilled and motivated. Are the drugs freely accessible and available at affordable prices? The systems configuration. Therefore, whether it's the determinants of health or the risk factors of health or the systems configuration or the community engagement, all of these become part and parcel of public health education. And therefore, public health has to be open not merely to medically trained individuals, but to everybody else. And even the capacity to integrate routine data into decision making becomes an important function. Just to give you a case in point, if we were supposed to be looking at how primary healthcare is actually responding in a village level or in a ward level to the COVID-19 containment challenge, what kind of data we need? We need data on the socio-demographic profile of the population group. We need emerging epidemiological information. We need information on the health workforce composition and availability. We need health system capacity and readiness. We need supply chain status of testing kits, PPEs, and medicines. We need transport data on entry and exit of people into that community. And we need, of course, as I said, community mobilization as well. Therefore, there are multiple sectors that are involved in this process. And public health has to recognize whether it is the appropriate use of artificial intelligence or whether it is actually engaging the human intelligence much more effectively in behavior change. Public health has to actually integrate learnings from multiple disciplines for multisectoral application. And that's why public health education in our setting in the Indian Institutes of Public Health is open to everybody who has graduated from any discipline, but ultimately they stream towards public health and public health management in a very integrated fashion. Medical education, too, has to become substantially broad based and holistic because without integration of some of these social sciences, understanding basic health economics, of knowing what is the incremental cost and effectiveness of a particular new diagnostic test being added to an old diagnostic test, you could be wasting resources and you could be employing multiple diagnostic tests with biological and financial cost to the patient. So you must also have some idea of behavioral change. So the missing E's of a medical education are epidemiology, economics, ethics, and empathy. And all of those need to be brought back into medical education, whether we are going to combat COVID or any other challenge. Therefore, I believe that while we have had professions which are very critical, we need to actually reform them as well to make them much more service-oriented in terms of their social responsibility. Since you are a management guru, let me just make a statement, maybe perhaps challenging a bit. The difference between business management and public health management is that business management brings in efficiency and profit. The mantra of public health management is efficiency and equity. So there are differences that we need to bring in even as we integrate all of these disciplines into a pool of learning that can be beneficial for society. Thank you.
Well, thank you so much. I think we are now beginning to reach the end. And before I come in with my closing remarks, I would be grateful to listen to Mr. Vora by way of his thoughts on where does he see us proceeding from what we have discussed today and what we would look upon as closing remarks before I come in with my winding up remarks and the vote of thanks. Over to Vora sir.
Thank you very much, Professor Gautam. I would not say very much at this stage except to take serious note of what Dr. Paul has said about the resource issue. A resource issue not only vis-a-vis the union, but the union and the states. If it is going to remain somewhere around 1.4% or move to 1.8 or even 2%, while meanwhile the population has grown by several hundred million, then the per capita ratio would remain the same, perhaps even go down. Insofar as the present and the future desirable health management systems are concerned, Professor Reddy has said enough in his earlier observations and now, and I think we take note of all of them and see what kind of discussion we can think of in the coming weeks to take this entire story forward. But one thing I would like to reiterate, which Dr. Paul hinted at and Professor Reddy has said it in quite so many words, is the entire business of medical education, the system. And what do we teach in BBS and what do we teach in post-graduation and so on? Knowledge of the humanities, social sciences, economics, epidemiology, and so on. All this is necessary for every doctor at every level of functioning to have a certain kind of perspective about the job he's performing, which is a difficult job anyhow. In this question of what is the cost of healthcare when we neglect other segments, which Professor Reddy has adequately referred to, For instance, to give a crude example, ready to understand, the pollution levels in Delhi or the NCR region, they cause so many million cases of asthma or chest diseases and result in premature deaths, reducing the span of life. See how much cost goes into the treatment of these millions or these lakhs and a loss of life apart, overall suffering and the overall loss to the nation. Then this question of 1.4, 1.8, or 3.5 or 6% assumes a different perspective. So I would say that the nation, the union, and all the states need to have more frequent, more serious discussions on these issues involving the elected representatives, the parliamentarians, the legislators, our faculty members in the universities, not only in the medical universities, but also in our other universities, our mainstream universities. What is health all about? Why is it that 70 years of free India, we have no public policy schools? We have no schools or areas of learning. We have a few nascent areas, new institutions teaching public policy, Ashoka University or Jindal University or some other universities have opened new departments. But I would say public health is a very, very large area and it's by definition multidisciplinary. I would end up by saying that we have heard some very wise statements and some very relevant observations. We need to put them all together and see how, as Professor Reddy said just now, that public health management, unlike corporate management, will have to ensure not only very high level of efficiency and delivery, also equity. The question of access, the poverty-stricken people, the several million and several hundred million below the poverty line, how do they get the medical care, which is not possible? I will close there, and Professor Gautam, before I close, to thank you also, besides Dr. Paul and Professor Reddy, for the care you have taken to put this thing together. And needless to say, we will have to think of a series of other discussions of how to carry the debate forward, in which we will need both Dr. Paul and Professor Reddy once again, because this question of per capitas and so on is not going to be resolved in a great hurry because states, by and large, even the prosperous states, the largest states are doing well. They are very niggardly when it comes to dealing with public health issues. They want everything to be done by the center. And I would suggest to Dr. Paul to please consider in Niti Yoga some kind of arrangement, a series of ongoing lectures, public lectures, and IC will happily associate and collaborate, where people like him and Dr. Reddy and other eminent members of the medical science fraternity, they speak publicly and the word goes around, and some people in the media also need to be oriented to play up these issues and not merely to publish the number of people who died and number of people affected, how many beds are missing and how many ventilators are not there. I think we need to look at the larger issues. And one last word, Dr. Paul, since you are directly involved and directly concerned. My own experience in regard to medical scientific administration. If we use the word MCI, Medical Council, Dental Council, Nursing Council, and all this, I think we need to totally change the erstwhile concept and the erstwhile approaches. Some of them are not even very honest, if I may say so, in terms of recognition of institutions, in terms of what is what and equivalence and so on. I would say that alongside all that we have said today and heard these two eminent persons, I would say that we need to travel a great deal of distance in terms of medical administration. It is not entirely left to civil servants and bureaucrats. We need more and more medical scientists coming forward and leading the whole campaign, the whole mission. because we need to travel a great distance. I thank you very much once again. And Professor Gautam, you can now proceed to do what you wish to do.
Thank you so much, as usual, giving me a carte blanche to weave together a temporary pause to this continuous dialogue which we have initiated today. My own take is a very simple one, rooted in my own experience. When I attempted to bring in management education in the engineering environment, my canvas was IIT Delhi, and it took me 17 years to convince my distinguished colleagues that through interdisciplinarity of engineering and management, we only make a good engineer a better engineer. And they bought it. And IIT Delhi had the privilege of having the first statutory department in management. Therefore, the objectives which Dr. Paul and Dr. Reddy have by implication suggested, and you have lent your support to it, is bringing an interdisciplinary perspective to management curriculum, management extension, management care is not all that remote. It can be done, and it should be one of the expected outcomes of this experience of COVID-19, traumatizing as it has been in parts. But Dr. Paul's testimony provided that no matter how traumatizing it can be, human spirit can always respond. I would like to make a few closing remarks to highlight something which is very close to my heart, essentially building upon the arguments which have been so eloquently made by the two speakers. We must understand the ways and pathways of how to reach communities. This is not only a postmodernist phenomena, but it has to use the conventional modes of communication, and that is how it travels. If I had the time, I would have explained how Mohandas Karamchand Gandhi ji, Mahatma Gandhi, as is a popular reference to him, used folklore and folk methods as a method of welding together the nationalist movement through the country. And I think here is another case where a Jan Andolan has to be released. I would like to make a few quick references to the technological dimension, because health and hygiene without technological intervention doesn't really go very far, but we will have to wait for an appropriate time to explore it. To sum up, therefore, two concluding thoughts. One is, we need to look at inter-country experiences to see how some of the other corporates, governance, NGOs, and social frameworks institutionalized are responding to the situation. I'm in touch globally for keeping in mind the various hats that I wear, to know that there are corporate enterprises in Canada, Singapore, elsewhere, which have even attempted doing a manual of going back to work. It has to do with restructuring of workplaces, a new architecture of work distribution, and how to combine working in the office with working at home. I think our corporates would be well advised to look at the experience of COVID-19 to redesign a new work method. I will not refer to the financial and the economic aspects of debt and credit. That would be a separate case altogether. But the second one of the two observations which I thought I should refer to, we will never have a perfect method, but we can always have an approximation of the perfect method. And I draw upon Dr. Paul's reference of talking of pathways to say we need to create delivery channels, delivery vehicles, and crafting a holistic response. The word holistic there is meant to say how you can put together different pieces to create an integrated picture. And in that, traveling together may be as much of a joy as reaching the destination itself. Thank you all for making this possible. It has been worth every single days of effort which we have put in together as a team since early June. And thank you, Mr. Vora, for supporting it in more ways than one. Dr. Paul, for being there almost without choice to whenever I reached out to you. Dr. Reddy and I go long years back in many ways. Reference to it is unnecessary, but then that's a friendship I depend upon. I would also like to make a reference to the director of the India International Center, Mr. Srivastava, who at one stage of the conversation said, Dr. Gautam, why do you worry if you don't get somebody, just talk to me. So that kind of a carte blanche is the spirit in which India International Center works. Tete, as the head of the program, has done a splendid service. The vendor has put through patiently an activity which was at the time, at a simple moment of time, both fulfilling and challenging. But that's the way it always goes when you do something as different from the normal run of affairs. This is by no means even a pause. This is just a water break. You can have your nimbu pani and come back till we get back at it with a little more thought at it, with a little more broad-based activity. Thank you, Vora Saab, for providing this your effort, your patronage. Look forward to seeing all of you not before long. Thank you, everyone.